Retinoblastoma. It is a malignant tumor arising from immature neuroepithelial cells, also known as retinoblast, within neurosensory retina. It can occur in one or both the eyes. It is the second most common tumor in the eye after uveal melanoma. Then we'll come to the etiology. It constitutes about 3% of all childhood cancers. Most commonly, it is seen between 1 to 2 years of age. There is no sex predilection. When we come to race, it is rare among Negroes. Laterality. 70 to 75% of the cases are unilateral, while 20 to 30% are bilateral, in which one eye will be severely affected. When we come to genetic causes, the transmission can be non-hereditary or hereditary, in which non-hereditary is the most common one and it is always unilateral. And there can be 30% sporadic cases. When we come to hereditary, it can be unilateral or bilateral, non-familial or familial. The mode of inheritance of retinoblastoma is autosomal dominant. So, genotypically, it is autosomal dominant. The gene RB1, which is a tumor suppressor gene located 13q14, undergo mutation. This Knudsen's two-hit hypothesis is very important, which states that loss of heterozygosity leads to malignant transformation and presentation. Here, two mutations occur, and the second mutation is after birth. And this retinoblastoma is phenotypically autosomal recessive. Now we will learn about pathology of retinoblastoma, which is frequently asked during the exams. Its origin is from immature retinal neural cells, which are small round cells with large nuclei. It is a tumor of a group called small round blue cell tumor. Under microscope, we can see rosette formation, in which flexnointestinal rosette is highly specific of retinoblastoma, in which they have central lumen in which cells are arranged outside. Then comes Homer-Wright rosette. Here there is no empty lumen. Here cells are arranged around eosinophilic processes containing neurofibrils. Then comes florets. It is a bunch of undifferentiated tumor cells which resemble photoreceptors and form like a bouquet. Then we have pseudo-rosettes. Here cells are arranged around the blood vessel here. These are the microscopic findings which are very important. Then under clinical features, it is divided into 4 stages. First one quiescent stage, second one glaucomatous stage, third one extraocular extension, and fourth distant metastasis. In quiescent stage, the patient will present with leukocoria, which is the most common one. Here, yellowish white pupillary reflex is seen in the 60% of the cases. Then we will be having squint. Usually it will be convergent esotropia. Then nystagmus is rare, but if it is seen bilateral. Then defective vision can occur, though very rare. Then in quiescent stage, ophthalmic features of intraocular retinoblastoma occurs before the appearance of the leukocoria. In the fundus examination, after full mydriasis is performed in the children presenting with strabismus, poor vision or other quiescent features, or on screening in predisposed children, may reveal the growth. Ophthalmic signs are of 3 types: endophytic, exophytic and diffuse infiltrating tumors. In endophytic retinoblastoma, the tumor grows inwards from the retina into the vitreous cavity. Under examination, we can find well circumscribed polypoidal mass which is white or pearly pink in color. It will be having fine blood vessels or hemorrhage on it. On calcification, it gives a cottage cheese appearance. It may be multiple growth projecting like a seed into gel. Exophytic retinoblastoma grows outwards and separate retina from the choroid. On fundus examination, it gives a retinal detachment appearance. In mixed, we will be having both. Under diffuse infiltrating tumors, like here, it shows placoid thickness of retina, not mass diagnosed late. Then comes glaucomatous stage or stage of painful red eyes. We'll be having redness, pain and watering, and this is due to secondary glaucoma or intraocular inflammation or orbital cellulitis. Acute secondary glaucoma is due to the tumor which is pushing the lens iris diaphragm forward or tumor cells which gets clogged in the trabecular meshwork. This stage is associated with enlargement of the eyeball causing ophthalmos with apparent proptosis, congested conjunctiva, cornea will be hazy and intraocular pressure will be raised. Then comes intraocular inflammation. Here it presents with uveitis associated with pseudo-hypopyon. Then comes orbital inflammation which mimics orbital cellulitis. Then we have stage of extraocular extension. Here progressive enlargement of the tumor will burst through the sclera, usually near the limbus or optic disc. This will cause rapid fungation and involvement of extraocular tissue, and this will cause marked proptosis. Then we have stage of distant metastasis. Here the lymphatic spread will be first to the pre-auricular lymph nodes and the other neighboring lymph nodes. The direct metastasis will be through the optic nerve to brain, which is common. Then we have classification. Under classification, international classification of retinoblastoma, which is presently being followed worldwide to decide the treatment modality, consists of 5 groups. First one, group A, which is very low risk. Here the tumor is less than 3 mm and confined to the retina, but greater than 3 mm from fovea and greater than 1.5 mm from optic disc. Under group B, this is low risk and the tumor will be greater than 3 mm and less than 3 mm from the fovea and less than 1.5 mm from the optic disc. Then we have group C, which is moderate risk. This includes retinoblastoma with focal seeds characterized by subretinal or vitreous seeds which is less than or equal to 3 mm from retinoblastoma. Then comes group D, which is high risk. This includes retinoblastoma with diffuse seeds characterized by subretinal and or vitreous which is greater than 3 mm from retinoblastoma. And last we have group E, which is very high risk and extensive retinoblastoma in which tumor is touching the lens or neovascular glaucoma or anterior to anterior vitreous phase or involving ciliary body, etc. When we come to diagnosis, ocular examination is done under anesthesia and fundal examination of both the eyes should be done with full mydriasis with atropine. Plain X-ray of orbit is taken which shows calcification. LDH will be increased in the aqueous humor. USG, CT or MRI can be taken to see the extension of the tumor to the orbit. In the B scan, it is good enough to show the mass and calcification, while CT scan is used to prevent the radiation sarcoma, also intracranial invasion. MRI is done to see extracranial invasion. Treatment, we have conservative tumor destruction which will save the eyeball. This is applied from grade A to D. Here we give multimodal therapy. This chemotherapy is done using three main drugs: carboplatin, etoposide and vincristine. Here, standard dose CVE regimen is 3 weekly 6 cycles of carboplatin on day 1, vincristine on day 1, etoposide on day 1 and 2. These are the doses specified. Then we have high dose for group D, that is 3 weekly 6 to 12 cycles, carboplatin on day 1, vincristine on day 1 and etoposide day 1 and 2. And these are the doses. We should study the doses. Focal therapy is given depending on location and size of the tumor. Cryotherapy, which is triple freeze thaw technique, that is 3 mm into 2 mm anterior to equator is performed. Then laser photocoagulations, which is posterior to equator. Then thermotherapy, which is diode laser, here also posterior to equator, away from macula. These are the locations of the tumor. Then we can give plaque therapy, external beam radiotherapy. Then we have enucleation for group E. Enucleation is done if the tumor is greater than half of the retina, optic nerve is involved, glaucoma is present, then we can do enucleation. It is enucleated. Eyeball is enucleated with maximum length of the optic nerve. Here, we should take care that we should not perforate the eyeball. After this, post-operative treatment should be given EBR, that is external beam radiotherapy, chemotherapy, that is CVE plus cyclosporin should be added. Then we have palliative therapy, in which the prognosis is dismal. Here RB with orbital extension, intracranial extension, distant metastasis, we should give this CVE therapy plus surgical debulking of orbit plus external beam radiotherapy. Then the last mode of treatment is excenteration of the orbit. Thank you.